Medicine and Pharmacy, Carol Davila from Bucharest, part of our faculty. 10 years he was here with us. Unfortunately, he is not in Bucharest now. I suppose he's in Cardiff. Are you in Cardiff, Alan? Okay, you are home. But hopefully in the next couple of months it will be possible to see you again and to have face-to-face meetings. So Alan, thank you very much again for being with us. Your lecture for today is echocardiography in heart failure with preserved ejection fraction. You did a lot of work in this field. We started together many years ago, and we are still doing a lot of scientific work, research in this particular field. Thank you very much, Alan, for being with us.
Thank you, Dragos, and I hope you'll interrupt if you're not able to see the slides, but you should have them now. Good morning, everyone. Thank you for the invitation, and I'm happy to meet you on the cloud, if not in person in Bucharest, and to talk about diagnosis and classification and prognosis in heart failure with preserved ejection fraction, and I have no conflicts of interest for this presentation. I'd like to start by going back to basic principles, just to remind ourselves that heart failure at basic level is the inability to meet the demands of the circulation. So the primary function is cardiac output. We tend to concentrate on ejection fraction, which is not cardiac output, and on filling pressures, which may or may not be a consequence of the myocardial problem that's causing heart failure in most cases. Remember, the heart, as you hear on the left, more like a piston, the left ventricle at least. And we know that in this scheme, which I've used for many years and which holds the test of time, that long axis function of the ventricle, the piston-like function, is improved with athletic training and declines with age and multiple risk factors. There is a change in shape in the ventricle with more stretch of mid-wall fibers. So as a consequence of the Frank-Starling relationship, radial function, at least initially, seems to increase, which preserves ejection fraction. When we have heart failure with reduced ejection fraction, of course, all of these are low, and diagnosis is not so difficult. And we still use ejection fraction, although it shouldn't be the only criterion. But it doesn't work for heart failure with preserved ejection fraction because of the balancing of subclinical changes in longitudinal shortening of the left ventricle with the change in shape and increased radial function. So with that background, what do we actually know about what limits exercise? And this is a summary from a meta-analysis published a few years ago. And if you look from the left, these are standardized mean differences showing the magnitude of change that correlated with decreasing severity of exercise capacity, decreasing severity or reduction in exercise reserve in patients with HFpEF. And indeed, filling pressure came out as the most important. That correlates both with myocardial function and with heart rate and with relaxation because of an interaction. But the next factors are the heart rate response and the arteriovenous oxygen content difference and the stroke volume index. So these are about cardiac output and peripheral oxygen delivery and extraction. So this is back to what I've just shown, cardiac output, at least as important as filling pressures. And then the other factors are ejection fraction, stroke volume index, and pulmonary arterial pressure. But the heart volume, you see, isn't predictor. And these are some of the functions that I've just mentioned, summarized on the right, reminding us that we should also be thinking about peripheral arterial oxygen delivery and utilization when we look at mechanisms of symptoms in these patients. Now, some years ago, in our European collaborative study of HFpEF called MEDIA, we looked at stress echocardiography. And if you just concentrate on the healthy subjects in blue and the heart failure with preserved ejection fraction subjects in yellow, and here is long axis function recorded as a septal systolic velocity, or a velocity profile throughout the cardiac cycle, comparing these two groups. And you see we cannot discriminate them on long-axis systolic function at rest, although there is some difference on exercise. The primary differences are in early diastolic filling, as you can see in these interquartile ranges of normal and abnormal values on those graphs. And with that, we were able to show that suction reserve and increase in stroke volume was markedly impaired in HFpEF compared with blue, which was the age-matched controls. Now, is this reflected in the diagnostic criteria and recommendations that we have? As Dr. Kionsa has just shown us, there are many, many recommendation and consensus documents, almost too many. The heart failure guidelines of the ESC are being revised currently and will be published again this year. But they have extremely simple diagnostic criteria, which in fact I find not helpful for recruiting precise studies of patients where we want to look at particular mechanisms and responses to treatment. We have diagnostic recommendations 2016, but they were changed from the previous version in 2009 as a consensus agreement without evidence, which to me now is illogical. And they've had a major implication for the prevalence of diastolic dysfunction that I will show. There is a new statement coming from the EACBI later this year on multimodality imaging in HFpEF, and I don't know what that will show. And we have, of course, the consensus statement on HFpEF from the Heart Failure Association that I was involved in, and I tried to persuade people to evaluate the algorithm before it was published, but that wasn't done. So all of these tend to rely on consensus statements almost more than evidence, which is unfortunate. And yet let's look now at the evidence. Here in very large studies, you can see the numbers in yellow from the Swedish Heart Failure Registry on the left and from the recently published National Echo Database in Australia on the right. And this is the benefit now from large data that we can have such studies being published. On the left, you see that in Sweden, they looked at the impact of ejection fraction as a diagnostic criterion across the whole range of values. And it is very poorly predictive of survival. And on the right, if we apply the diastolic grades from the consensus statement from 2016, in nearly 500,000 people, you see very poor diagnostic discrimination between them. And yet these are the criteria that are mostly recommended. What could we do better? I personally think it's high time that we should change the normal ranges of ejection fraction, but consensus groups are remarkably resistant to criticizing tradition, although we do have the evidence, because here you see in 250,000 men, cardiovascular-related mortality with respect to ejection fraction. And the healthy value is more than 60%, but not very high. And at any level below 60%, there is increasing mortality. So this shows no evidence for using mid-range ejection fraction. There is no inflection on the curve. And it would support us thinking about 60% as the cutoff normal value in men. And now looking at women, it's exactly the same. 60% or below was where you see the increase in mortality. So we should be using ejection fraction if we want to keep it differently. And here is the impact of the change in diastolic guidelines from 2009 on the left to 2016 on the right. And this is from a database of 71,000 patients now from Vancouver. And we reviewed other similar studies in this commentary accompanying the publication. But look here at mild diastolic dysfunction in the upper age groups and how that has changed and reduced significantly in prevalence with the new recommendations. And unfortunately, if you look here, the indeterminate category actually even increased so that with the new recommendation, in this study, at least 43% could not be graded. So I would question the value of recommendations that are inapplicable in as many as half of our patients. And moreover, between these two versions, the agreement was actually very disappointing with kappa only 0.3. Again, the recommendations were tested or validated afterwards. And here is the Europhilic study comparing the two to assess diastolic dysfunction, although we used the reference criterion of left ventricular filling pressure. And there was an increase so that the sensitivity increased significantly from 43% to 75%, but at the cost of quite a low positive predictive value. And I just want to highlight here the problems with E over E prime, that its diagnostic performance in this group as a single marker of high filling pressure was very poor. If it's abnormal, indeed, it's likely that there's disease because there's high specificity, but the sensitivity is very low. And in HFpEF, there was no significant correlation between E over E prime and the measured filling pressure. Let's look at one example that helps to show us how E over E prime is limited. And if you want to see more examples, we have reviewed those recently in the publication that's listed at the foot. But here is a 50-year-old lady with symptoms of heart failure with a very short mitral deceleration time of 79, a very short isovolumic relaxation time of 83 milliseconds, and yet good early diastolic long-axis velocities, giving an E over E prime index that is within the normal range. If you look at the M mode echo of the left ventricle, you can see very rapid expansion of the cavity dimension in early diastole, but then it doesn't change. And this patient indeed had a very severe restrictive cardiomyopathy that was familial, and she went on to have transplantation like her father. But the point is, this is just one example, and I could show many, of severe diastolic dysfunction where the E over E prime index tells us virtually nothing. So what should we do instead? Going back to our media study again, we published a protocol for studying patients during submaximal exercise. Many studies look at patients at the end of exercise, which is difficult. And here's a normal resting heart with the global longitudinal strain being demonstrated. And you can see on exercise that ejection fraction is preserved and long axis function, if anything, is actually augmented. And compare that with a patient with heart failure with preserved ejection fraction, and he had a high BNP. There is an exercise response, but the increment of long axis function is reduced compared with a healthy patient. And now I go to the recommendations from the Heart Failure Association in 2019, and I don't have time to go through this algorithm in detail, but I want to highlight that E prime on its own is in the document, which it wasn't with the previous version by Paulus, and highlighted in yellow, long axis systolic function is included, but only at rest. So we need a standard criteria for assessing exercise responses, if possible with relatively simple indices. That document recommended a scoring system, which you will hear more about in the case presentation. And it was not so dissimilar from another scoring system that had been published just before and was actually validated both in a test group and an independent retest group. But look at the criteria from this score from the Mayo Clinic, and you can see the only echo criterion might be E over E prime, which I've just said is of debatable value, and the presence of pulmonary hypertension. So although this was well done, it's heavily weighted towards atrial fibrillation, and it does not include natriuretic peptides, both of which in most other documents are important criteria in suspected heart failure with preserved ejection fraction. And in our media collaboration, we had baseline data on 515 patients that has just recently appeared in press. And here we compared a new score, which includes E over E prime, the pulmonary arterial pressure, evidence of congestion in the right heart, and long-axis systolic dysfunction, not E prime but S prime, and at the lateral wall rather than the septum for actually good reasons, which I can discuss if you wish. But he identified that compared with either the heart failure score or the score from Reddy and colleagues, we could improve on the prognostic value of these scores with actually quite a good discrimination, as you can see on the right. And this is survival without heart failure problems or rehospitalization. Now, the problem here, of course, is that we are using scores that were diagnostic when they were introduced to calculate prognosis. And that means they're very dependent on the pre-test probability and the particular characteristics of the group that is recruited. So there are problems with all these scores. And indeed, when you compare the two main scores that I've mentioned, as was done again in a large number of subjects from the ARIC study in the USA, both scores were high in only 4% of patients with unexplained dyspnea. So these two scores essentially are identifying different cohorts of patients, each with a poor prognosis. As you can see on the right, it worked, but they're different groups, which would be complicated for identifying patients for specific treatments. And I don't have time to go into this in detail, but we see now very many studies using artificial intelligence and machine learning to try to identify different types of pathophysiological mechanisms and clinical phenotypes in heart failure. And this is a nice review that summarizes some of the different mechanisms. Unfortunately, with all these studies, and we've done some as well with our patients, they all identify different groups, variably between 2 and 6 phenotypes within heart failure with preserved ejection fraction, according to papers that I know. And I haven't seen any studies that use imaging data and genomics and proteomics and biomarkers and clinical criteria in thousands of patients with exercise responses. And that's probably what we need. So to try to summarize these initial comments, we need some clinical guidance as to what to do currently, where this field of guidance documents is very confused. I think it is easy to rule out heart failure with preserved ejection fraction, perhaps if BNP is normal, but not only that, if the ventricle is not enlarged, if there's no hypertrophy, if the left atrium is not increased in size, and if there is normal lung axis function, then that's probably a normal heart with another cause for breathlessness. E over E prime can be useful, but I've shown you an example where it doesn't work, and at best it's only one marker, and we should look at other markers of diastolic function. And I haven't shown the data, but actually, in my opinion, in most patients, it does not help during stress echocardiography. Again, I'd be happy to discuss that. So we need to look at these patients in detail and analyze mechanisms pathophysiologically using echo now as a non-invasive hemodynamic laboratory. And we need to wait for clinical decision tools to be developed by integrating the functional characteristics with all the other available data. And I'm confident that that will happen within a relatively short time. Until then, I think we should look at long axis early diastolic velocities. We should not forget about the relaxation time, the E deceleration time, and the mitral inflow velocity. We should certainly use pulmonary venous flow if we can, because actually that's much more accurate than E over E prime, in my opinion. And in patients with atrial fibrillation, of course, things like the L wave can be very important. I'm going to finish with this line at the bottom, which again comes from the National Echo Database in Australia, and I show it because it's such a huge population that is now in press also. And they showed, just like the ejection fraction that I demonstrated, cut points beyond which mortality from cardiovascular causes was increased. And these are the cut points that we could consider using. 90 centimeters for the mitral E velocity, higher is worse. Septal E prime less than 9 centimeters per second. a cut point of 9 for E over E prime, and a slightly lower volume index for the left atrium, as you see there. So I hope that's both some insight into where we stand and where we need to go and what we can do currently. Thank you very much. Mulțumesc.
Thank you very much, Alan, for this excellent and very provocative talk. I'm sure we can ask a lot of questions and we can discuss a lot of issues. I'll come back to some of them during my talk. And now, și acum trecem mai departe la prezentarea de caz, Roxana Rimbaș.
Thank you for the introduction, and also thank you very much for being here today with all of you. My mission today is to illustrate some of the difficulties in HFpEF diagnosis. I will start my presentation soon, I hope. I will start my presentation with 4 main ideas in mind. Differentiation between cardiac and non-cardiac dyspnea is crucial. Moreover, differentiation between HFpEF and diastolic dysfunction without HFpEF in resting condition is crucial because prognosis is completely different and the NT-proBNP level might not be available or low. However, we all know that none of the conventional transthoracic parameter alone predict increased NT-proBNP level. And in real life, the diagnosis of HFpEF is obvious in the patient with congestion, but the evaluation of euvolemic or hypovolemic patient with exertional dyspnea presents a real challenge. Let's start with the first case. It's about a 64-year-old woman with hypertension, with triple therapy, diabetes, obesity, and paroxysmal atrial fibrillation. Came to our lab for moderate exertional dyspnea. Of note, she had right coxofemoral prosthesis. No particular sign on ACG, as you can see. And the NT-proBNP level at rest was 92 picogram per milliliter. Global systolic function was preserved with ejection fraction of 57% with normal cardiac output without significant valvulopathies, with mild LV hypertrophy and moderately dilated LA. And if we look at the diastolic dysfunction profile, we can see low E prime velocity, increased E prime ratio, LA dilation, and increased tricuspid velocity. And if we look on diastolic dysfunction algorithm, certainly we have diastolic dysfunction, and our patient had diastolic dysfunction grade 2 with increased LA pressure. Also, a patient has low global longitudinal LV strain. But if we return to the definition of the HFpEF according to 2016 guideline, we have all data, symptoms and echo data, but we don't have NT-proBNP level. HFpEF seems unlikely in our patient according to 2019 consensus on the use of NT-proBNP concentration. Moreover, American and European score for HFpEF probability disagree in classifying our patient. As you can see, by using American score, we can classify our patient as having HFpEF. However, by using European score, our patient is indeterminate zone, having morphological, functional criteria, but without biomarkers criteria. Because LA deformation analysis has been already found to be a better predictor for increased filling pressure than E prime ratio, we decided to add LA deformation parameters. As you can see, all deformation parameters are decreased, being highly suggestive for HFpEF in our patient. But why is NT-proBNP level so low in our patient? Is it because we have an obese patient in which lowering the established cutoff value by up to 70% seems to be reasonable for optimizing diagnosis accuracy, or because we have improper circumstances for NT-proBNP collection? What should we do to solve the dilemma? The European consensus of HFpEF suggests that in uncertain cases we should perform diastolic stress tests, but our patient cannot do this. We decided to do a 6 minutes walking test in order to reproduce symptoms. And as you can see, this dyspnea on Borg scale was significant. And after 30 minutes, we collect NT-proBNP, and the NT-proBNP level exceed the threshold value for diagnosis of HFpEF. Indeed, we have a patient with HFpEF now. The second case is about a 78-year-old woman with hypertension treated with diuretics and AC inhibitors, recurrent orthostatic hypotension, exertional dyspnea, and important fatigue. NT-proBNP level at rest was 107 picogram per milliliter, and no particular findings on ACG. Global systolic function was preserved, but the patient had low cardiac output without significant valvulopathy, with LV hypertrophy and important LA dilation. Diastolic profile was similar with the first patient, with low E prime velocity, increased E prime ratio, important dilation of LA, but with tricuspid velocities under 2.8. If we look on the diastolic dysfunctional algorithm, clear we have diastolic dysfunction, and our patient had diastolic dysfunction will increase LA pressure, diastolic dysfunction type 2. LV global strain was also decreased, and LA deformation, as you can see on the right, it's severely depressed, reservoir, booster pump, and conduit function. But once again, our scores, American and European scores, cannot classify with high probability patient as having HFpEF. We also have functional morphological criteria, but without biomarker. So the main question is why is NT-proBNP so low in this patient? I think in this patient, the only available answer is improper NT-proBNP collection hormone and hypovolemia induced by diuretics. We choose to re-examine the patient after 5 days without diuretics. And as you can see here, the blood pressure stabilized. The patient had normal cardiac output, had a similar diastolic profile, but A velocity increases, E on A ratio increases, and E prime ratio increases also tricuspid velocity increases. Moreover, NT-proBNP level at rest exceeds the threshold for diagnosis of HFpEF. I think our patient is here. We have a variation with fluid or the diuretics regarding diastolic profile. I will finish my presentation with some important messages. Normal NT-proBNP level at rest does not exclude HFpEF. Hemodynamic conditions are very important in the interpretation of NT-proBNP level and also in the interpretation of echo parameters. Do diastolic stress test when it's feasible, in some of uncertain cases, not in all. NT-proBNP perhaps should be measured after a standardized echo protocol in uncertain cases. And finally, I think we need to find a combination of parameters that are able to predict with good sensitivity and specificity the transition between preclinical dysfunction and HFpEF. Thank you.
Oksana, thank you very much for these very nice cases, which are now open for discussions. Do you have any questions from the audience, which is quite big now?
Dragoș, can we use break time to ask questions?
Yeah, we use the break time to ask questions, and then we go directly to my talk.
Okay, so may I have one or two questions for Professor Fraser?
Yes, of course.
So, Professor Fraser, I fully agree with you, but ejection fraction, it's a continuum, and also recent epidemiological studies show no inflection point at 40 or 45%. However, it's a category of patient between 40 and 60 or more than 60, where we don't have what is called evidence-based heart failure therapy. Neurohormonal medication are working only in patients with ejection fraction less than 40, CRT it's working less than 35. So how to call this category between 40 and 60?
I would be more radical. I think we should define heart failure by cardiac output response to exercise, and by estimated filling pressure. And I think we can look at ejection fraction as a screening tool, but it shouldn't be a key criterion on its own for heart failure. Or if it is, it needs to be coupled with at least the nominator or the denominator in the ejection fraction, probably volume and systolic volume. Unfortunately, guidelines groups are very conservative and they say they want to stick with tradition, but that's to me completely inconsistent with the principle of producing evidence-based recommendations, because we now have large volumes of evidence. And the problem is that unless we change these criteria,
Conectez un pic iubirea.